So I'm back with Chapter 61. This is care of the patients with urinary problems. You have some pretty basic concepts here. Again, we're going over elimination. The priority concept is elimination. The interrelated concepts for this chapter are pain, immunity, and tissue integrity. So here are your objectives, and of course, patient-centered care, providing safe care, and prevent infection, collaborate with other healthcare uh, groups, and promote health maintenance, um, encourage clients to have adequate fluid intake, teach people how to reduce or prevent urinary tract infection, and also the psychosocial integrity to reduce that impact of the urinary problems for the patient and the family, and physiologic integrity, coordinate care to prevent urinary tract infection among hospitalized patients. That's very important. So when we're looking at pathophysiology, we're going to be looking at people who have different kinds of stress incontinence. And what is incontinence? It's an involuntary loss of urine that's severe enough to cause social or hygienic problems. And so what we're going to try to do is to plan on this stuff. We want to make sure that the types of incontinence include stress, urge, overflow, and functional. Now, do I want you to know these? I'm afraid I do. What is stress incontinence? That is an involuntary loss of urine during activities that increase abdominal and pressure on that detrusor muscle. The detrusor muscle is what is where the sphincter is located, and that is where you want to when you strengthen that muscle when you do exercises. They are unable to tighten the urethra sufficiently to overcome that increased pressure on that detrusor muscle, and so then they leak urine. An urge incontinence is when you have an overactive bladder, and I know you've seen that on TV where the bladder leads this lady around and takes her to the bathroom quite frequently. That is an involuntary loss of urine associated with a very strong desire to urinate. You can't suppress the signal from the bladder muscle to the brain that it's time to urinate. You can't suppress that urge to urinate. And then you have overflow incontinence. That is an involuntary loss of urine associated with overdistension of the bladder when the bladder capacity has reached its maximum. So it just goes, they don't go to the bathroom, and they don't go, and the bladder's stretched so far, and then it overflows, and you don't get to the bathroom quickly enough. Sometimes that's caused by that detrusor muscle inactivity or underactivity, and can also be caused by a bladder outlet dysfunction, or some kind of obstruction that won't allow the bladder to fully empty. And then you have functional incontinence, and that is leakage of urine that's caused by factors other than disease of the lower urinary tract infection, or urinary tract, not infection per se, but diseases of the lower urinary tract. So sometimes this is caused, the incontinence can be caused by um, surgery, spinal cord injury, of course, brain and nervous system disorders. Treatment of some diseases can cause people to have urinary incontinence, especially if they're on a diuretic. Drugs, again, if they're on diuretics. And factors associated with aging, especially in women who the urethra gets a little bit shorter as we age, and so we can't get to the bathroom as quickly as we want to. And so you're going to ask some questions because as many as 45% of women over 65 report that they do have leakage. And so you're going to ask them, do you ever leak urine or water when you don't want to? Do you ever leak urine or water when you cough, sneeze, laugh, or exercise? Or if you're headed to the bathroom, do you not get there in time? Do you leak before you get there? Do you ever use pads, tissue, or cloth in your underwear to catch urine? And if the answer to these questions are always or sometimes, then you want to do a focused assessment on their uh, elimination patterns. So you're going to assess the bladder and you're going to look at everything and you're going to ask them about these chronic conditions that they may have here, especially with women who've had vaginal deliveries or have a pelvic prolapse, men who have prostate problems and diabetes and heart failure, and those who are obese. So those are things that you're going to ask them, and you would sometimes they will you would inspect the external genitalia, and sometimes you may have to put on gloves and go into the vagina to test the strength of the muscles in the urinary tract muscles. So, digital rectal examination may be done on both male and female patients. Um, the history is very, very, very important, and we just went over that pretty much about what you're going to ask them. And then you're going to do the abdominal um, assessment and look for prolapse of the uterus, I mean, of the bladder down into the uterus or in that area. You would check to see if the bladder has prolapsed. And the digital rectal examination will certainly be done by the healthcare provider if there is any indication that they need to. Um, the laboratory assessment, we know that a urinalysis is very, very useful to rule out urinary tract infection, and you absolutely want to make sure that you do a clean catch. We'll be looking for red blood cells, maybe some white blood cells, and some leukocytes or nitrites. This is an indication for doing a culture, and so you want to get a good specimen and see if that's what's causing the incontinence. And then sometimes they will do imaging, certainly do a post-void residual urine that would be done by a bladder scanner. And if they have to be, they can catheterize the patient immediately after voiding to assess residual. CT is useful for looking for abnormalities and avoiding uretherogram, which is what that VCUG is. That can be done to assess the size, shape, and support of the urinary tract system. And also, urodynamic testing may be done, and that can take several hours and more than one visit. So that would be something they might want to do. And EMG, which is electromyography of the pelvic muscles, they would do that to test for their the the strength of the muscles. So, your cues here. What are your cues? What do you want to do? These are how we're going to prepare for our patients to see what needs to be done. So it's kind of like a nursing diagnosis, and what it is that you're going to assess them. They may have an altered urinary elimination because they're incontinent. And like I said, that's very embarrassing for these people. And they also, if they pee on themselves, they can have altered tissue integrity. So that makes sense, doesn't it? So that's what you're going to be kind of looking for, and what your thoughts would be when you're assessing your patient. So, what are you going to do? Well, um, you're going to promote urinary elimination. That's what you're going to do. You're going to make sure your patient can void and void appropriately. So, a non-surgical management would be nutrition therapy. Might look at their nutritional status. Do they have good protein intake to help build muscles? And you would have your outcomes. You would want them to have optimal urinary elimination and tissue integrity and comfort. So your nursing interventions are going to be um, done for the management of the different types of urinary incontinence. And you're going to focus on restoring continence. And non-surgical management, as I said, includes nutrition therapy, drug therapy, some devices. They can do electrical stimulation, MRI therapy, um, pelvic muscle therapy, the Kegel movements, vaginal cone therapy, and some behavioral interventions. Um, Maintaining a diary can help these patients with stress incontinence to see what the pattern is. You want to um, use collection devices, the patient does, absorbent pads and undergarments, because they may need to be studied for quite some time, and patients need to know about these pads and stuff that they can use while they're trying to see what's going on. Nutrition, weight reduction is very helpful. Um, Patients who are obese sometimes have trouble voiding or getting completely emptying their bladder, and there are some irritants such as caffeine and alcohol that can contribute to urgency and frequency. So you want to stress the importance of maintaining an adequate fluid intake. Some drug therapies, sometimes estrogen is used in the perineal and vaginal orifice to help treat the postmenopausal problems with stress incontinence. And sometimes hypertonic bladder contracts involuntarily in patients with the urge incontinence, and sometimes they can give them drugs to help to relax that smooth muscle. Um, Sometimes they will give them beta adrenergic medications to reduce the urge incontinence. And there's just a lot of drugs out there. Even Botox can be used. So you have to know what your patient is taking, or what it would be recommended for them, and you may have to look it up because there's a lot of drugs out there, um, cholinergic medications. There's just very, very, very many, and sometimes they're short term, and sometimes they will use other methods to help the patient to retain or to not void on themselves. Also, some devices, they may use uh, intravaginal pessary to support the uterus and the vagina and help the position of the bladder. Um, Male patients may want to use a condom catheter, and sometimes there are some female collecting devices. Electrical stimulation is either intravaginal or intrarectal electrical stimulation to help treat the urge, stress, and mixed incontinence. But this is done in the office, and it can be done 2 to 3 times a week for about a couple of months. And then magnetic resonance therapy. This involves targeted urinary tract nerves and muscles for depolarization, and they sit in a chair that has a magnetic device that helps them depolarize and helps that reduce the stress-induced incontinence. It's kind of like a relaxation of the muscle and the nerves. And then pelvic muscle therapy, those are the Kegel exercises for women with stress incontinence. Strengthens the muscles of the pelvic floor. And also they can do vaginal cone therapy, which is where they put weighted cone-shaped weights up in the vagina, and they um, uh, help with exercising those, and they tell the patient has to learn how to do it, of course, but it's she tries to hold the cone in place while she walks around, and it goes from small weights, larger weights, and usually about 15 minutes twice a day. Also behavioral interventions, bladder training and habit training to reduce urinary incontinence. The patient is totally involved in this and has to have explanation of the problem of urge incontinence, and instead of the bladder being in control of the patient learns to control the bladder. And then you have surgical interventions, and those surgical interventions, sometimes they can do a surgical sling or a bladder suspension procedure, and they can also inject agents, bulking agents into the urethral wall to provide resistance to urine outflow. So there's lots of things that can be done for these patients, and you have to, of course, always you're going to be teaching, and you're going to teach the patient about the procedure and clarify any of the surgeon's explanations. And after surgery, you would assess for and intervene to prevent or to detect any complications. You want to make sure that that you keep them safe, and that if they have a catheter in place, they have to you have to use proper catheter care, and you have to maintain their tissue integrity. A major concern with the use of wearable protective pads is the risk for skin breakdown, loss of tissue integrity. Uh, People will develop incontinence associated dermatitis even when the skin is kept free of contact with urine. The pads can cause them to have heat and sweat in the area, and that can cause dermatitis. So the skin integrity is of utmost importance for these patients. So if I ask you that, you would want to say, Make sure that they don't have any skin breakdown, right? Absolutely. And make sure that if they use any external devices or containment materials, you want to ensure that they do not have any alteration in their tissue integrity, because they have to have a dry environment. Okay, so now let's go to what you do for these people who have the incontinence. How do you take care of them? How do they go home? What do you have to teach them, of course. Community care based for these patients. You have to consider their personal, physical, emotional, and social resources. You want to be sure that the primary caregiver um, knows what to do, and especially about the skin integrity. The non-pharmacologic and non-surgical treatments can provide significant benefits for these people and have a low risk for any bad effects, but they have to be able to adhere to the teaching. So home health care resources is good. They can assess always. That's one of the things home health care management includes always. Safety. Assess the home environment for barriers that limit access to the bathroom, and eliminate hazards that might slow walking or lead to a fall. Of course, you want to make sure that they understand the education, the self-management education, and you may need to refer them to home care agencies for help with their personal care, or to go to a continence clinic that will specialize and evaluate them. Sometimes they collaborate with other health professionals to evaluate and manage patients, and the treatment plan has to be specific for each patient. Um, and supplies and products are always custom for each patient, because everybody needs something a little bit different sometimes. So, your evaluation. You need to be able to evaluate your outcomes. And what would your outcomes be? Well, your expected outcomes are listed here. Maintain optimal urinary elimination through a reduction of the number of urinary incontinence episodes. You want to reduce the many times they go through this every day. And again, maintain their tissue integrity of their skin, especially in that perineal area. They can get galled and they can have yeast infections. Demonstrate knowledge of the proper use of the drugs that they're given, and if they have to self-catheterize, they need to be able to do that. If they are using an artificial sphincter, that they open up and let the urine come out. Sometimes prostate patients have those, or care of an indwelling urinary catheter. And you want to demonstrate an effective use of their exercises that you give them for their bladder training program. And of course, select and use incontinence interventions, devices, and products. Now then, let's talk about some of the things that these people have. What if they have to have surgery for TURP? A TURP is necessary for people who have prostate problems. This is surgery. This is a man surgery, and these people have sometimes it's just a benign um, tumor of the prostate, or sometimes it's cancer. So the main thing is they're going to remove parts of the prostate gland through the penis. And when they do that, they're going to put a three-way Foley catheter in place, and that will be in place for 1 to 3 days to help urine drain while the prostate cancer um, or the gland heals. And please, please know that there will be lots of blood in the urine after the surgery. These people with that three-way drip, they need to know that the nurses that taking care of them need to know that they cannot let that drip run dry. It's called a Murphy drip, and it's a three-way catheter. So one of the ports is used to flush this fluid going in to flush the blood and potential clots out of the bladder and the catheter. And the main thing here is you cannot let it run dry. If you let it run dry, it gives it a great opportunity to clot, and then the patient ends up with all that fluid in their bladder and very uncomfortable, and the doctor will be terribly mad at you and will just cuss and carry on. After this kind of surgery, they have to avoid strenuous activity for 4 to 6 weeks and to avoid lifting items greater than 20 pounds. They need to take in lots of water, 6 to 8 glasses of non-alcoholic fluids to minimize the clot formation. I can attest to this, okay? I know I've taken care of patients with a TUR so many times. And used to, we did not have the three-way. Well, we did have the three-way, but we had to flush it manually. And we were constantly, these were one-on-one patients, and I did work in ICU. And we had to be in there constantly pushing fluid into the bladder and pulling it back out to get those clots out. And if you let them clot off, then Katie barred the door, because the doctor would have to come in and he'd have to do all this stuff, and he might have to change the thing, and it's hard to get it back in. It's just a terrible, terrible thing. So no clot, please, no clots. They want to avoid straining when they're defecating for at least 6 weeks after surgery to prevent bleeding. And lots of times we would prescribe prune juice because it would help. Okay, so now let's talk about urinary retention. This is more common in men than women. The average age is over 60, and they may possibly require hospitalization. The urethra becomes blocked. When it's blocked, it cannot drain urine, and the urine will back up into the bladder, and sometimes the prostate will cause that, or it can be caused by stones or strictures. Sometimes fecal impaction can cause it, and people who have prostatitis and prostatic carcinoma or benign prostatic it's not hypertrophy, it's hypertrophy, retroverted uterus, or surgery, and sometimes there is a urethral rupture, or they have clots in the bladder because they're bleeding in the bladder. That can be some sort of carcinoma or something. So urinary retention is the inability to empty the bladder. Ooh. Chronic urinary retention, they may be able to urinate, but they have trouble starting a stream or emptying their bladder completely. They can urinate frequently and feel an urge or a need to urinate, but they don't go very much when they go to the toilet. They may feel like they still have to go even after they've just finished urinating. With acute urinary retention, you can't urinate at all. Even though they have a full bladder, they cannot go. It's blocked off. So acute urinary retention is a medical emergency, and they have to go in. Sometimes they do a suprapubic catheter up above the bladder through the skin to let the urine drain out until they can fix whatever the problem is. This is uh, emergency, and it has to have a lot of people who have are men with prostate problems will finally just close off and they cannot go, and they come in and have to have emergent treatment. Chronic urinary retention may not seem life threatening, but it can be awful. It can lead to serious problems, and they do need to seek some help. Sometimes these medications, the anticholinergic drugs, atropine is one, or the alpha adrenergic effects, the antihistamines, can trigger this retention. So people who have these problems need to be careful taking those kind of drugs. Okay, urinary retention, your planning and implementation. You could require surgical intervention. Catheterization is first tried after avoiding trial. You want to prevent overdistension and retentions after surgery. You want to ask your patient to void every 3 to 4 hours. Your desired outcome here is bolded, and I have been known to ask questions about that. We want to make sure that there's less than 100 milliliters of residual urine in the bladder after they void. So they feel like they've gone to the bathroom, they voided, and then you want to make sure they have a residual of less than 100 milliliters. That's your desired outcome. And you want them to verbalize that their pain is relieved and that they can realistically cope with the pain if it's not completely relieved. Now let's talk about cystitis. Cystitis is an inflammatory condition of the bladder. Inflammatory. And it usually refers to inflammation from infection. Sometimes there are irritants that can cause cystitis without infection, but most of the time it is infection. Etiology and genetic risk of UTIs. Well, more than 80% are caused by E. coli. Catheters are the most common factor associated with new onset UTI in the hospital and in long-term facilities. Oh, this is not a good thing. You want to make sure you always use good hand hygiene when you're dealing with catheters. You do not want to cause a nosocomial infection from a catheter in the hospital. This is one of the national safety goals of prevention of CAUTI. It's a national patient safety goal, and each hospital has written criteria regarding the use and care of indwelling urinary catheters. This is huge and can cause people to have to pay a lot of money. They are not allowed to charge for this, and it can be quite devastating to people who develop catheter or infections from a catheter, and they can actually become septic and can die. And of course, it would cause them to be in the hospital longer. So this is a huge thing. So be sure that you use appropriate best practice for patient safety and the quality of care. This is very important. Only properly trained personnel can insert and maintain catheters. Um, you have to use routine hygiene to clean, and all of these things are very important. Use aseptic technique when you're getting specimens. Um, this is a awful thing when this happens to a patient. And of course, it is monitored and very carefully taken note of who put it in and who took care of that patient. So make sure that you're not one of them that causes that. Um, Interstitial cystitis is a rare chronic inflammation of the entire lower urinary tract, the bladder, the urethra, and the pelvic muscles. And it's usually genetic, and immunity dysfunctions can cause this too, but it's not caused by infection. Um, you want to make sure that you know their history and what kind of problems they're having. Okay, incidence and prevalence. This cystitis is usually caused by E. coli. It's second only to the upper respiratory infections in primary care, and it's the most common health care associated infection. Not a good thing to do or have. Okay. Um, what do they need to do? Health promotion and maintenance. The main thing is knowing what you're doing when you're inserting catheters. That's why you have to be checked off. You cannot just willy-nilly go in there and insert a catheter. And no, you can't assign it to someone who has not been taught sterile technique when inserting catheters. You want to use clean technique. If they're using intermittent catheters at home, they need to be taught that. Single use catheters are recommended for home settings to prevent infections. And remember, the National Patient Safety Goal is CAUTI prevention. And of course, you want them to have liberal intake of water. How do you recognize cues? Well, physical assessment, you're going to be looking for frequency of urination, dysuria, that's painful urination, and urgency. And if you've never had a UTI, I'm telling you, this is all right there. That is exactly what happens. And it's very uncomfortable, and you can't sleep, you can't do anything. It hurts, and you have to get up 50,000 times and go to the bathroom. And you feel like if you don't hurry, you won't get there. Um, if they have, or anyone who has fever, chills, nausea, etc., this may indicate infection. And this infection um, may be, uh, it may spread, and that's very, if it goes up into the kidney itself, then they may develop pyelonephritis. So we don't want that to happen. Um, you want to assess a catheter if a patient has a catheter, and have them void so that their urine can be examined. And of course, always check their vital signs and look at their tummy and their bladder, if you can see it, or if it's the lower part of the abdomen, if it's distended, sometimes you can see it. So your assessment is also going to be to get a clean catch urine specimen. You want a urinalysis, you want a culture, you want sensitivity, you want to see what's growing in there and what it's sensitive to. And WBC with differential, you want to see what's going on with the cells to see what the white blood count and what kind of white blood cells they're manufacturing. They may need a pelvic ultrasound or a CT, and of course they may possibly need further investigation, and if they do, then they will have some more testing done, and they may do a ultrasound or a CT to see if they have an obstruction. They may do voiding cystourography, urethral urography, and that would be to see if they have anything going on inside that is causing scarring or anything like that. They may also have a cystoscopy to look for the if they have any non-infectious cystitis. They would have to go in there and look to see what is in there and what's causing the problem. So those are the types of things that you may see ordered. Non-surgical intervention for these patients include drug therapy. And drug therapy is indicated, of course, if they have um, bacteria or if they have any sort of infection. They may use antispasmodics. They may use to prevent that feeling you got to go all the time. They may have, they may possibly, of course, need to have antibiotics for UTI. And if they have a fungus, they would give them fluconazole. Uh, Sometimes you can get a fungus up in there, candida. That antispasmodic drugs can decrease bladder spasms. And a lot of times people who have catheters will have spasms, and sometimes they'll give medication to help with that. Of course, they may, like I said, they may have infection, and usually the treatment um, is 7 to 10 days. Sometimes an uncomplicated UTI in a person can be just treated 3 days. They find that this will uh, help people to maintain or to actually take the drugs. It's just for 3 days. But sometimes it has to be longer, 7 to 21 days, and sometimes they have to be in the hospital. Depends, just all depends. There is in some examples of drug therapy in your book. Um, these are some of these are sulfa drugs, so you have to make sure they're not allergic. Cipro is the one I'm most familiar with. Um, they have to take these whole. They can't crush them. Amoxicillin might be given, Cefaclor, or some of those type drugs may be indicated. Fluid intake, dear God, they need to drink, 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 drink. Sometimes they want them to have at least 1.5 liters of urine output to get rid of all that bacteria that's in there. So sometimes they want them to void at least 7 to 12 times a day. Like I said, that's how you get the bacteria out. Sometimes you can use sitz baths as a comfort measure, 2 to 3 times a day for 20 minutes. That can provide pain relief and some relief of local symptoms. If they're burning with urination, then you want to teach the patient to sit in the sitz bath and urinate into the water. That can help with the pain. And again, they might use antispasmodics. If they need surgery for cystitis, then they would use it to treat conditions that increase the risk for recurrent UTIs. And sometimes that's an obstruction or a repair of a reflux that they may have in the vesico-urethral reflux. That's what it's called. Some kids have that. You want to make sure that the patient understands what's going on. You need to assess their level of understanding and to make sure that they know what to do. Um, these symptoms can include discharge and itching and discomfort down on their urethral area, and you want to make sure that they know about that, and that if they have fever, with or without chills, they need to let their physician know. And you're going to address any concerns about their medications and with intimacy uh, regarding recurrent UTIs. Sometimes intimacy, sexual intercourse, um, may reveal that they're having that somehow they're getting a UTI related to that because of the proximity. So you would want to test them, of course, if they have uh, men have problems and they're having a discharge or have a urinalysis that has pus in it, then you're going to test them for gonorrhea or any STDs. You're going to test for chlamydia, um, and even HIV can be a problem. Pregnancy test, of course, for women who have unprotected intercourse. Um, they may have low estrogen levels. So we want to make sure that they take their medication, take all of it, and if they have other problems, um, then they would have to have follow-up care. So urethritis. This is inflammation of the urethra. This is inflammation of the urethra. This is uh, in adults 20 to 24, and like we just said, this is STIs, sexually transmitted, is most often the cause of this, and those symptoms would include the discharge. Um, this will usually resolve spontaneously unless there is STI detected. If they do find um, STI, then they would prescribe antibiotics. Urolithiasis is kidney stones, and I am a victim. Dear Lord, I have had numerous kidney stones, and it all started in my adult life, in my later adult life, and I did not know what this was when it hit me. Thought I was dying. Yeah, did. It was awful. The pathophysiology is, of course, stones in the urinary tract. The most common associated condition is dehydration, which would allow stones to form. And I guess as a nurse, yeah, you kind of get dehydrated sometimes. But as I said, the dehydration is a common metabolic risk, and family history, obesity, diabetes, and gout will increase the risk of developing kidney stones. The diet is also important here, and it's not just increased sodium, it's increased a lot of things. You can't eat almonds, you can't eat some nuts, you can't have tea. There's just a lot of things that I found out can cause stones to form, and didn't much care for the whole thing, if you want to know the truth. And I commiserate with anybody who has a kidney stone. It varies with geographic location. Why, I don't know. Maybe we just don't get enough water here. Your race, family history. Some people in my family, yeah, they had a stone or two now and again, but not 15 of the dang things. About 12% of adults will have at least one episode in their lifetime. Okay, acute pain. Holy Hannibal. Acute pain related to renal calculi. And the pain is caused by renal colic. It causes this dilatation, stretching, and spasm because of an acute ureteral, not urethral, but ureteral obstruction. It's in the ureter, and the ureter is T90, and some stones get really big. This is an excruciating pain. It comes in waves, and it radiates down toward the genitalia, and you feel like you're going to have to pee, but you can't pee, and it hurts, and you get nauseated, and it's just awful. So you're going to have impaired urinary elimination related to renal calculi. Um, they made me limit calcium intake and vitamin D enriched foods because mine turned out to be a phosphate and oxalate. So you want to make sure that you limit that kind of food. Um, and of course, animal proteins are a factor also because they can cause uric acid stones. So the best thing to do is to keep your urine pH at high levels um, so that you're alkaline, and you do that by eating fruits, green veggies, legumes, milk, and milk products. Okay, um, nephrolithiasis is the formation of stones in the kidney itself. Urolithiasis is the presence of calculi in the urinary tract. They don't cause any problems until they start to pass down into the lower urinary tract, and that's when it starts to hurt. And if you can, you want to drug these people to your best ability. These things hurt like hell. Non-surgical management is drug therapy and lithotripsy. Now, lithotripsy is where you get shock waves to your abdomen, and they generally will take you to surgery and put you to sleep because that hurts too, to get the lithotripsy. I have had laser lithotripsy and I have had regular lithotripsy. And I'm going to have to tell you that the laser is the best of the two. If they can't break it up, they have to go in there after it. And the procedure is actually fairly short. You're so happy to go and get this sucker out that you don't care what they do. They can do it under under minimum invasive procedure. Just go in there, put you to sleep with a little Diprovan or something, and go up in there and laser that stone out. I've had that 2 or 3 times, and I've had a regular lithotripsy, and that was kind of neat because I got to see. This is the only time that I got to actually get the stones out through my bladder down to void them out. And it was the most interesting thing. It made a noise. It was like plink, plink, plink when it went into the commode. It was pretty cool. But that's the only time I have ever seen my stones except in a test tube. The majority of adults who form stones have a metabolic risk factor. And these risk factors can be because they have diabetes or gout or hyperuricemia, and may have something that causes them to their diet may be considered a risk. So you want to make sure that that they know what kind of stone it is. You want to make sure that if it's an open procedure, if they have to go in there and do a basket extraction or go in actually cut into the ureter to get the stone out. And sometimes they call them stag um, uh, stones. They look like a big stag, and they can't be passed. And a lot of times that has to be removed surgically. So I've never had that kind, but I have had stones. You want to ask the patient if they have any family history, of course. You want to make sure that you prevent any infection because the urine backs up and it causes hydronephrosis, and that's when it becomes obstructed, and that is not good. That's another painful part of it, and it's so painful that you get sick. You throw up. It's a horrible, horrible pain, and um, so make sure that you know that what their history is, and um, manage their pain. And you do want to prevent obstruction, but if you come in with obstruction and they can't get it out, then you're headed for surgery to do an extraction, either a laser or you go get the lithotripsy. Um, it can cause damage to the kidney itself if you get obstructed and don't get it out. So let's talk about a patient here who had him a little stone. And this guy is a Caucasian male, and he's a student nurse. Well, nurses are always busy, busy, busy. And he came to the ED, and he had a 2-day history of left flank pain and gross hematuria. Now, stone will cause the irritation of that ureter, and that can cause bleeding. So he was having bleeding. He said the pain comes and goes and lasts about 20 to 30 minutes and is at times quite severe. He has no nausea, vomiting, and he's tolerating PO fluids well. Past medical history, he's 30 years old. He has no past medical history. He's not on any medications, but he's got a family history. His dad has kidney stones. Well, what are we going to do? Let's do our history. We just did that. There's his past medical or his present history. And he has a family history of urological stones. So we know that that's a problem. That's acute. So he may be having a kidney stone. His diet history. You want to know what he's been eating, has he been drinking fluids? We know that when you get busy, you fail to drink, or you drink your Dr. Peppers, and you don't eat well. Hey, he's a student. He's a medical student or a nursing student. So he doesn't have a past treatment, but you would want to know if he had, and you want to recognize that the urinary tract obstruction is an emergency. It is an emergency, and it has to be treated to preserve kidney function. Now, this can be um, um, quite damaging to the kidney. So his history. We're doing a social history on him. He's a non-smoker. He drinks a couple of glasses of wine every week, but who wouldn't if they were a nursing student? He does work long hours as a tech, and he doesn't drink a whole lot while he's at work, and there's a reason for that. You don't have time to go to the bathroom. There's just no time. He does drink his Dr. Pepper, and he takes a lot of caffeine in when he's on call. He just recently completed a marathon, and he currently runs about 20 to 25 miles a week. And he was on that Atkins diet, which is now called the keto diet. He was on that for 3 weeks. Now, think about that history, y'all. Think about that as we look at this fella and we say, What do I see here? He's completed a marathon. He runs 20 to 25 miles a week. You think he might be a little dehydrated? He's on an Atkins diet. He's taking in lots of protein, lots of fat, and he's been drinking his caffeine. And he's not been going to the bathroom very well. He's not been drinking lots of water, and he is a student nurse, so he has some um, problems getting his nutrition and fluids in. So, what do you think you would expect to see for this guy? Now, this is something that we haven't talked about yet because I want to discuss it a little bit right here. What kind of study do you anticipate here? Um, when I went to the ER, the first thing they did, and I was pitiful, I was throwing up everywhere, had no idea, I thought I was going to die. The current standard for confirming urinary stones is an unenhanced helical CT scan of the abdomen and pelvis. So, knowing that, this is probably what you're going to see done. Now, sometimes after I'd had my first one and then my second one, and I'd have to go back to see the doctor, and he's let me know that I had several in there, and I could anticipate having more problems. And every time I went to the doctor, they would do what is called a KUB. That is a routine abdominal X-ray, and that is useful to look to see exactly how many stones are in there because they show up. Oh, it was awful. I had so many stones. Anyway, um, stones are radiopaque, so they can see the size of them, the location, and the anatomic structures that's all around. So, what, saying that, you're going to anticipate that they're going to do a unenhanced or no contrast helical CT scan of the abdomen and pelvis, and it will show up if they are having stones, and it'll show exactly where they are. And then after they find it and treat it, what are the prevention measures that you're going to teach this guy to prevent future stones? Well, we'll get to that um, because that would be prevention of stone formation, and that will be our next slide. But first of all, when they are having this urgent problem, make sure you are not skimping on the pain medication. They gave me Dilaudid, and I thought I had disappeared to another universe. I have never in my life, they gave it IV. And that was the first time I had ever had IV Dilaudid, and I honestly thought I had left the building. I really could not, I was just like out there. But Lord, it did help that pain. It did. Now I still hurt, but it helped the pain. So I really want to stress that if they are hurting, that you do something for them. Um, this is not the time to um, not treat them. So how are we going to prevent stone formation? Well, we want to make sure that they drink extra water if they know they have had stones or have stones. Um, you want to make sure that it can dilute the substances that lead to stones. And they should drink 8 standard 8-ounce cups of water a day. That's 2 liters. Getting too little calcium can cause the oxalate levels to rise and cause kidney stones. Mine were oxalate. Um, you want to obtain calcium from foods, since some studies have also linked taking calcium supplements have been linked to kidney stones. Reduced sodium, high sodium diet can trigger kidney stones because it increases the amount of calcium in the urine. So if somebody is prone to um, uh, kidney stones, then you're going to suggest a low sodium diet. Limit animal protein. Eating too much animal protein, such as on a keto diet, can boost the level of uric acid and can lead to uric acid or uric kidney stones. Avoid stone forming foods. They took me off chocolate, which I loved. Beets, spinach, rhubarb, tea. I can't have tea. Most nuts are rich in oxalate, and colas are rich in phosphate. And both of those, all of those can contribute to kidney stones. So after I had my, oh gosh, I guess it was the sixth one, I had to have surgery. The last one I had to have done was a lithotripsy that was not invasive. And that's when I saw the light and did go ahead and try to limit my food intake of these things, because they did do testing on them and they were oxalate. So I don't drink a whole lot of stuff that can cause them, or eat a lot of stuff. I don't eat almonds at all. Okay, so what kind of test are we going to do? We're going to do a helical CT test. When we did it on this guy, it reveals one 7 millimeter stone in the left proximal ureter, and this is he's referred to urological consultation for evaluation of what would be the proper therapy. Well, they did do the extracorporeal shock wave lithotripsy, and he did fine. It is an outpatient procedure. It's done under the administration of a mild anesthetic, and that anesthetic is Diprivan, and Diprivan will knock you for a loop, and that's what I wanted to be. And so then, because it's very, very painful, they say, and because the shock waves they do it many, many times to try to break up that stone, and if they can't get it broken up, they're going to have to go in there and get it out. So they try very hard to get this sucker out, and it can cause pretty major bruising. So analgesics, absolutely. They're You want to make sure that you don't use a lot of NSAIDs, because remember, this is kidney problems here. This is sometimes they have to give antibiotics because they may need to have, they want to prevent any infection. But the lithotripsy is what this guy had, and they got his stone came out. The shock waves are at the rate of 60 to 120 minutes. They're applied over 30 to 45 minutes. Um, this is a rough procedure. People don't tolerate it well unless they are sedated. When I had my laser lithotripsy, they had to go in there, and when he went in there, he took the stone out and he lasered it out. So the stones, he just sucked them right on out while he was in there. Well, that can cause swelling in the ureter, and so they have what they call the stents. They put stents in there, and I've had 3 or 4 stents. I have one that if you want to ever see one, I can show it to you. It's a tube that's placed in the ureter by ureteroscopy, and it dilates the ureter and enlarges that pathway for the fragments or the stone to come out. One time I was hurting so bad when I went to the doctor's office. I got to where I knew what they were, and so I didn't go to the ER. I just went straight to the doctor's office. I'd call him up, and it's happened a couple of times while I was at school teaching, and had to go. Of course, they made me, somebody had to drive me, and so I went to the doctor's office, and I was hurting so bad I thought I was going to die. And I knew what it was. I knew exactly what it was, but it's so painful it doesn't help to know what it is. And so he said, I, he looked at the size of the stone. He says, you can't pass it, but I'm going to give you some relief right now. And so what he did in the doctor's office, he went in there and he put a stent in so that I could get the urine through there, and it didn't stop it up, and I didn't have the hydronephrosis, which was pushing the urine back up into the kidney, and that can damage the kidney pretty bad, and it also causes a lot of pain. So that is something else they can do. And he did that, and I wore it around until I went in and had the lithotripsy done. That was my last stone. Please, I'll knock on wood, and please, Lord, don't let me have any more. Okay, points to remember. This is very, very painful. They need dilaudid. They need lots of dilaudid. 5 millimeter stones are not likely to pass and require surgical or lithotripsy evaluation. All of mine have been well over 5 millimeters. I've had an 8, a 12, a 10, and an 11. I mean, I've had nothing that I could pass spontaneously. The funniest thing was, though, when I had my last lithotripsy, and that was the non-invasive one, I didn't pass those stones. I thought, well, this is weird. Where are they going? And it turns out they sit in the bladder until you pass them out through your urethra. So that's when I would see the plink or hear the plink plink, and it was just like little stones, little tiny round stones would be in the commode. It was the weirdest thing. I know y'all probably don't want to hear that, but it was. It was pretty cool. Don't want no more of them though. A non-contrast helical CT is the gold standard for diagnosis of a kidney stone. Okay? Alright, let's go ahead on here and let's talk about renal cancer. Renal cancer happens. You're going to assess your patient um, for clinical manifestations of renal cancer. Blood in the urine, abnormal urine color, flank or back pain, a lump or a mass in the kidney area. They can have swelling, weight loss. Men can have testicle enlargement. People get fatigued, have fever and anemia. It can mimic, and this is the bad thing, it can mimic less serious conditions and be metastasizing to the lymph nodes in the brain, lungs, or bone in the surrounding organs. So, they will recommend a bone scan for assessment of potential skeletal metastasis if they have a elevated alkaline phosphorus. Alkaline phosphate is found in all tissues of the body, but most of it is derived from the liver and the bones. So if this is elevated, if the alkaline phosphatase is elevated, then they can have either liver or bone disease. And sometimes this can be the very first indication of an underlying medical problem. So you want to make sure that you know about these tests that they're going to do. Obviously the liver function test, the calcium, the ESR, PT, APT, This is because of clotting. They're going to do a CT scan. They may do ultrasounds, arteriography, and they may do an MRI. If they have an elevated alkaline phos, then they will do a bone scan. Um, and if it's in the bones, it will light up like a Christmas tree. I had to go with a patient once who had that, and it did, and it was terrible. It was all in his bones. So you want to make sure that you are teaching the early signs and symptoms and the need for early intervention for those who are at risk, and to educate them about possible relapse for those who have been treated. So, um, urethral carcinoma, bladder cancer. This is a common urological cancer. It is the fourth um, most frequently diagnosed cancer in men, and the 10th most common in women. Older adults, of course, are more likely to develop this because of the immune degradation of the immune system as we grow older, and it is more prevalent in Caucasians. I knew a nurse who had bladder cancer. No, I take that back. She had kidney cancer. We'll talk about that in a minute too. I have had patients who had bladder cancer. This is greatly attributed to carcinogens in the urine, and smoking cigars or pipes increases that risk. So, if your patient smokes and you want to ask them, well, do you smoke cigars or pipes? Because that does increase the risk of bladder cancer. Age, chronic bladder inflammation, the diet high in saturated fats, radiation, of course, can cause it. Being around industrial chemicals can cause it. Chemical exposures at work. People who work with certain chemicals or in certain industries have a greater risk of bladder cancer than the general population. Organic chemicals called aromatic amines are particularly linked with bladder cancer, and these are chemicals used in the dye industry. So other industries linked to bladder cancer include rubber and leather processing, textiles, hair coloring, paints, and printing. So these people, smoking is the greatest risk, but these other things can cause bladder cancer. It's classified as grades, low grades, which is 1 to 2, and high grades, which is 3 to 4. Well, how do we treat this? Well, most times, if it's a bladder cancer, they're going to do a transurethral resection with fulguration. And what they do is they put a little wire loop and they go up in there and they remove that cancer or burn the tumor away with electricity. Again, they probably will have a catheter, and you want to make sure that it doesn't run dry, and that you make sure that all the blood is coming out and not clotting. They may need to do a radical cystectomy, and that is surgery to remove the bladder and any lymph nodes. In men, the nearby organs are removed, and that would be the prostate and the seminal vesicles. If they have a partial cystectomy, they remove part of the bladder, and this may be done for patients who have a low-grade tumor that has invaded the wall of the bladder, but it hasn't gone anywhere else. Because only a part of the bladder is removed, patients are able to urinate normally after recovering from this type of surgery. If they have a radical cystectomy, they may need to, or they will need to do a urinary diversion. And this is a surgery to make a new way for the body to store and pass urine. Well, a urinary diversion is a term that's used when the bladder is removed or the normal structures are being bypassed and an opening is made into the urinary system to divert the urine. It is diverted through an opening in the abdominal wall. Individuals who have this will require um, pouch. These are people whose bladders have been removed that are not functional or needed to be removed due to cancer or some sort of injury. Okay, problems with urinary diversions may include alterations in fluid and or salt balance. They may have difficulties in inserting the tube in those with surgical openings in the abdomen. They may have problems with the skin growing over that surgical opening. And they may even have complications because they had an abdominal operation and now they've got a bowel obstruction or they've got urine leakage and bowel leakage. So, most of the time, urinary diversions are tolerated well. Patient has satisfied, they're very happy with it, and they're rehabilitated to normal activity and normal lifestyle. If they have the whole bladder taken out and they put a neo bladder in, then they use part of the large bowel. Now, if they do that, they of course need bowel prep. Um, so they would decide what kind they're going to do, and it's based on the urologist's recommendation. If it's non-continent, that would be the ileostomy. If it were if they had a continent one, which means that they just put a new bladder in that made it out of the bowel, they have more complications and they have to have a functioning kidney, and that means their GFR has to be at least 60. If it's below 60, they're not a candidate for having a neobladder. What they do is the neobladder replaces the bladder by using a part of the large bowel, and it's attached to the neck of the urethra, and it will store the urine, and they urinate through the urethra just like you did before. Continent urinary diversion describes all forms of urinary diversion that enable the patient to urinate at his or her own discretion without the use of any form of appliance or collecting device. That would be a continent diversion. Okay, they can do the yeah, they can do the neobladder or they can do a non-continent diversion. And the non-continent diversion, which is called an ileal conduit, is where they take a segment of the bowel, it's removed and transformed into a urinary channel or a conduit, and it will connect to one end of the ureters, and on the other side it would connect to a stoma that they would open in the wall of the abdomen. And this procedure is called a urostomy. So all of these are going to include some sort of a prep because they will use some part of the intestine to make these things. Usually they're tolerated pretty well, and the patient satisfaction with these is really pretty good. Okay, how are you going to recognize this? Well, What's the main thing you're going to ask them? You're going to ask them, do they smoke? Have they had active or passive exposure to cigarette smoke? You want to ask them about their hobbies, their occupation. What do they work with? Do they work with paints? Do they work with dyes? Where do they work? Changes in urinary habits, presence of any abdominal symptoms such as the pain or abdominal swelling. Check their skin color, their nutrition status, and their abdomen. You want to make sure that you are looking at their abdomen for any asymmetry or anything that looks like it's bulging, or if there's a knot or something that you can see or feel. And of course, examine the urine for color and clarity. And a lot of times you may see blood or you may not see blood, but you're going to look at the urinalysis when it comes back and make sure that it didn't have microscopic blood. And of course, assess their psychosocial status and their method of coping, because this does scare you to death, and it is a change in lifestyle. So, um, we are going to be looking at diagnostic assessment now. Diagnostic assessment includes the um, um, sorry, lost my place. Diagnostic assessment is routine urinalysis. Is it gross or microscopic hematuria? Do they have, that's a significant finding, so they would follow up on that. They may test voided urine specimens for cytology. Usually that's not very helpful. They may do a cystoscopy to evaluate painless hematuria, and if they see a visible bladder tumor, they may biopsy that while they're in there. This is essential for staging, and they may do cysto ureterography, and that may help identify any obstructions, especially where the ureter joins the bladder. CT scans may show tumor invasion surrounding tissues, and ultrasound may show a mass, but it won't tell you about the staging, so they would have to do a biopsy. So MRI may help also, because they can use it to look deeper into the abdomen to see what's going on. So what are we going to do? We are going to do some health promotion and maintenance. Stop smoking. Um, Use any kind of work that is dye products or textiles or any gaseous chemicals. They should wear protective equipment. They must wear the mask. They must do that. This will help them not have the exposure that they might develop this cancer from. And this is your urothelial cancer. Um, Shower or bathe and change clothing as soon as they have any contact with those chemicals. Non-surgical management includes immunotherapy. They can do some immunotherapy um, with uh, bacil calmette urine, a BCG. That's what they use. This is a live virus compound, and it's used to treat tumor recurrence or of superficial cancers. It's more effective than single agent chemotherapy. And usually, what they'll do is they'll put it in there and in an outpatient setting, and it will dwell in the bladder for a couple of hours, and then when they urinate, that live virus will be excreted. Multi um, agent chemo can be successful in prolonging life if there's been distant metastasis, but it doesn't usually occur or cause a cure. They can do radiation therapy to help prolong life. Surgical management is depends on what kind of situation they have. If they do a complete bladder removal, of course, they're going to need some way for the urine to collect, and so that would be the ileal conduit, a continent pouch, or even bladder reconstruction. That's the neobladder. And of course, like I told you, it depends on their health and what they have of their GFR. So it's really important. And of course, when you're doing these, you want to make sure that you have the patient prepare for the impact of this treatment. You want to help them to have a self-management education for whatever they end up with. That's a huge teaching thing. If they're going to do a ileostomy, they would, of course, need to mark the place where they're going to do it, and you want to make sure it doesn't. They don't have it on anywhere there might be clothing over it or anything like that. You want to make sure that a belt doesn't go around the ostomy or anything like that. So it does take a wound ostomy nurse should be involved in this education. Health resources, you want to have resources like the United Ostomy Association or the Wound Ostomy and Continence Nurses Society. Um, this can cause impotence to men, but the treatment is available. Um, there is going to be an impact if there's a urinary diversion on their self-image, body image, and their self-esteem. So those are things that we want to make sure that we address. All right, this is question 2. A healthy 20-year-old reports to the college health center reporting burning upon urination. What priority question would you ask? This is a young 20-year-old. The answer is A. Are you sexually active? The most common cause of urethritis in men is a sexually transmitted infection. That includes gonorrhea, gram-negative bacteriums, chlamydia, Trichomonas vaginalis. So you want to make sure that you know if they have been sexually active. Okay, the second question is, a nurse is caring for 4 patients. Which client does the nurse identify that is likely experiencing stress incontinence? The client who laughs and cannot retain their urine, client who feels an urge to urinate and immediately does so, a client who has dementia and does not understand how to toilet, a client who has not voided in 12 hours and experiences minor leakage. Stress incontinence. stress. What do you think about this question? Talking about stress incontinence, we went over that. So let's see, can you figure it out? They laugh and cannot retain their urine. A client who feels an urge to urinate and does so immediately. A client who has dementia and does not understand anymore how to toilet. Or a client who has not voided in 12 hours and experiences minor leakage. I really hope y'all get this. What causes a person to pee when they have stress? When you are doing something and it causes you can't retain your urine. It's the client who laughs. You can't retain your urine because you're laughing, coughing, sneezing, jogging, or lifting something, and you just spurt. A little urine will come out. The second one has urge incontinence. Let's go back and look at that. The second one was what? The client who feels an urge to urinate and does so immediately. Well, that is urge incontinence. The client C has overflow incontinence. And client D has functional incontinence. The nurse has placed an indwelling urinary catheter via sterile technique into a patient. The nurse recognizes that this is how long before bacterial colonization begins. What do you think? Is it within 12 hours, 24, 48, or 72? Well, let me tell you that the answer is C. 48 hours. You got 2 days. That's when that's what they look at when they're doing these audits. If a person is diagnosed with symptoms of um, uh, infection after they have had a catheterization, or even after the catheter is removed, in 48 hours, if they have developed a infection, the colonization will begin along the urethra and the catheter itself. So risks for infections associated with a catheter increases 3 to 10% per day that the catheter is in place. So 48 hours. And that's why they want you to get these catheters out as quickly as possible. Okay, that ends this chapter 61, and this is the chapter on clients or patients with urinary problems. There's a couple of more chapters to go, so bear with me, but this ends chapter 61.